Hi, y'all. This is our final narrated lecture used to accompany the textbook slides and various online resources posted to the module. As a manager, leader, and follower, you are a change agent. In our presentation objectives, I like to recap prior sections because this lecture brings it all together. Such collaborative work demonstrates the qualities of professional role development. In this slide, we revisit some key terms, differentiate among them, and describe the characteristics. Recall, leadership does not require a title. Similarly, one who assumes title of manager may or may not be a leader. Agreed? How do these characteristics look? Be sure to include the role of follower. Are these roles interchangeable? Can one be a leader yet at times be a follower? One of the statements I have here, which is guided by your textbook, is better care does not equal satisfaction. What do you think is meant by this? Well, how is care delivered? Are you kind? Are you considerate, courteous, humble? Do you show gratitude? If we are working with and through others, we need to consider the individual in the equation and appreciate each other's strengths and contributions. TEAM. Together, everyone achieves more. We have compared and contrasted manager versus leader throughout the course. It is important, too, to make the distinction between a team and a group. It would be appropriate to say as a class, you are a group. You collectively work together for a purpose. In this case, that purpose is to learn professional role development and earn a grade that eventually leads to a bachelor's degree. What are some examples in nursing that are considered groups? A committee, a task force, or a council. A council such as those created in a shared governance model. Groups are created to provide a forum for the exchange of ideas and/or to promote interdependent work accomplishments. Consider working together on the infographic, information technology. Initially, you are a group. You are paired up. Work development tends to follow a process of stages. First, you orient yourselves to each other, followed by adapting. That is, you determine roles and the structure. And then the stage of emergence, which is where conflict may occur or power struggles arise. You determine how to consolidate your shared identity and purpose so that you can accomplish the project successfully. And then last, you get to the actual work for the task or purpose. Now, when each of us comes together, not just for a common purpose, but are collectively committed to a goal, using our complementary skills and shared accountability, we are a team. Team building is essentially unifying. Recall from the first lecture presentation, the IOM has set the following 6 areas for improvement. A, safety. B, effectiveness. C, patient-centeredness. D, timeliness. E, efficiency. And F, equity. Similarly, we use the quadruple aim guidelines that also focus on patient care, the patient experience, improving health, reducing costs, hence efficiency, and I like this one, improving the work life of care providers. Yes, managing self. No need to memorize. I simply shared to illustrate how we can best accomplish these improvements through teamwork. Teams infer collaboration and cooperation. So what exactly does it mean to be a change agent? We use that term a lot in nursing, particularly in BSN programs. Nothing, I hope, is meaningless in our LCSC's program, and most certainly in my classes. So let's apply this term to our role as manager, leader, and follower. Managing a team improves organizational and unit efficiency by promoting high-quality performance and outcomes. As a leader, you ought to know how to create, lead, and manage professional teams, and yes, even at times follow. People are more likely to follow and commit when they feel they belong and have a sense of ownership in the decisions. If you have the right people in the right position and for the right task, go, launch. What a beautiful thing will unfold. The positive team dynamic. So, to be a change agent is to serve in all three roles to advance improvement and progress, and do so through and with others. Although change is inevitable, it does not have to be catastrophic. On the other hand, sometimes the change process, recall we can apply a nursing's ADPI, assess, diagnose, plan, implement, and evaluate, may show that everything is okay, just as is. Please do not walk away thinking that everything, whether it be nursing or healthcare in general, has to always change. There are those times that such a process shows that what is being done is good, it's working well. Regardless, never underestimate those involved, nor discredit by whom the change impacts. I provided a quote from one of my PhD faculty that I think says it all. People don't resist change, they resist being changed. Think about that for just a second. We change all the time. It may be as simple as changing from an iPhone to an Android, or changing the series we are watching on Netflix. But the minute someone tells us to do that, what happens? Granted, some examples are more explicit than others, but you know where I'm going with this. You want to see resistance? Come in like a bulldozer and implement a change without any consideration to others, and it will fail horribly. How best to be what we coin as a change champion, or as our textbook authors describe as a change leader, change whisperer. Think of the 4A model of change leaders. 1. Acknowledge thoughts and feelings. 2. Align with your purpose and values. 3. Create agency with solid, genuine choices. And 4. Adjust your attitude as needed. Energize, motivate, and engage. Let's continue the topic of champion/change leader in the next slide. The change champion is willing to stick his or her head out to advance what is best for the profession and really place of employment. It takes courage, boldness, and the ability to appreciate each member as unique, all the while maintaining our humility and willingness to learn too. All of us, including me as your course instructor, are lifelong learners. This is where theory helps. Use your textbook and other resources I provided in the module to choose a theory or perhaps even a combination of theories for your proposed change project. Consider the process of change behavior instead of the change itself. Furthermore, think long-term instead of short-term. Common change theories include Lewin's change theory, Lippett's phases of change theory, Rogers' diffusion innovation theory, and social cognitive theory, or SCT. I particularly like the SCT when it comes to changing behavior because the central concept is self-efficacy, that is, one's perceived capability to accomplish and sustain a behavior. As nurses, we promote efficacious behavior in nearly everything we do with our patients. There is a great deal of evidence that supports the linear or positive relationship between self-efficacy and behavior modification. You will learn more about how evidence is generated and the types of studies, such as correlations between two variables, in the evidence-based practice course. With each theory, consider the stages people will go through, including the driving and opposing forces. An example of an opposing force would be a lack of social support or a support system. Also reflect on the need for positive health outcomes in other areas. In one of the videos I included in the module, the speaker shares how human interactions are analogous to birds of a feather flock together, such as smoking. Smokers stick together because that behavior is supported and what is normal for that social unit, which in turn attracts other smokers into their network of friends. Using smoking cessation as a change behavior and how that could apply a positive outcome to other areas may be, well, clothing no longer smells like a cigarette. The person chooses to smell or smile more often because their teeth are whiter and their home is cleaner. No more nicotine scents in the furniture and vehicle. Again, if we are thinking sustained long term change, then we definitely want to make sure all these factors are addressed. Sometimes it's as simple as remembering our patient has his or her glasses on or hearing aids in. Well, of course, there is a knowledge deficit. If the person can't see or hear what we're teaching, change as a process must entail one's personal attributes, traits, beliefs, values, expectations, motives, affective and emotional state, habits, and their perceived capability and cognitive ability. Dr. Azen from Boston University says it best. If we want to change behavior, we need to change the attitude of the behavior first, right? We can build a free medical clinic, but that doesn't mean people will come. We can provide statistics about the ill effects of a sedentary lifestyle and poor eating habits on heart health, but that doesn't mean people will fear a cardiac event. Open-ended elicitation questions to better understand your targeted audience or individual. What I mean by elicitation is we want to get the most and in-depth information from them. So instead of saying something like, the doctor was just in and told you that you have emphysema. You mentioned you get a little winded while playing golf. You got to quit smoking. You ready? You could instead phrase it something like this. How do you feel about stopping? Tell me about the disadvantages in quitting. Do you believe you could make a plan to reduce the number of cigarettes you smoke over the next 2 weeks? Do the people most important to you want you to do this? And if not, let's talk about that. Click on the links to the right side of the slide. These are great videos I want to include because both highlight nurses as courageous change agents. Again, you'll have to open the link outside of the PowerPoint and then come back to resume. And so the future holds. Tuck these characteristics into your pocket. They will serve you well. Moving on, this slide is a hallmark statement as to why we instructors do what we do in nursing school. Granted, most of you are already licensed nurses, and if you aren't, you are close to graduating, but we must ensure that you are safe and a competent care provider and trustworthy. We can teach nursing skills to anyone, but we can't teach how to be a nurse to just anyone. This is more than a job or occupation. It is who we are. You will move forward in other courses, one of them being the next or continued role development class, unless you are taking it now. I encourage you to apply these concepts to understand people and yourself. These are key to success. So, mediocrity versus excellence. I have always said in the different institutions I taught, which includes all levels of undergraduate nursing, from LPN and ADN programs in the community college setting to Texas A&M University and LC State. Graduates are no better based on where they went to school. Compare yourselves locally. Are you more or less a BSN prepared nurse from LC compared to, say, Gonzaga or BSU or heck, Texas A&M? Perhaps the rigor differs for sure, but I can honestly say, based on my years of experience as a nurse educator, the answer is no. The quote here, I replaced the word pastor with nurse. I think it's great and fitting. You can be average. It's easy to be average. In fact, average infers we met the minimum standards to pass nursing school and subsequently boards, the NCLEX. But I want each of you to strive for more. Have a great aspirations for yourself. It is about you and who you are and what you bring to the table to make nursing good. It is about integrity, your willingness to learn and listen. Avoid the know-it-all attitude and owning your mistakes. You are human before you are a nurse. Now, go enjoy working with one another, applying your leadership style. Consider theories here too. Are you transformational, task oriented? Perhaps you assume different roles. Certainly makes sense considering you may be in the position of follower in one circumstance and leader in another. Regardless, create a positive and fun working environment and advocate for each of your patients. Advocate for the profession. This too is reflected in your organizational memberships and policy work. Your actions may look like the story I heard years ago about a nurse who snuck in a 110-pound St. Bernard dog into the ICU to help lift the spirits of one of her patients. She knew it was against policy, pre-COVID, by the way. When the manager called her in and asked her why she did it, she replied, I'm paraphrasing here, it worked, and it's worth sitting here today asking for forgiveness than to have asked for permission and be told no. Now that hits the heart of nursing. We're done. Here is our final slide and final lecture presentation for this role development course. The references used are listed here. Any questions, please do email or call. I'm happy to help. Have a great day and a rest of the week.